A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9:15 a.m. to 9:45 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. These regulations are to improve and maintain the standards of the CPD programs conducted by SRI, and thank you for the strict adherence. So today our topic is Exploring Pediatric Oncology, Insights Through Case Scenarios. The guest speaker for today is Dr. Prabani Maddumarachchi, consultant in pediatric adolescent oncology and special interest in stem cell transplant, National Cancer Institute, Sri Lanka. Over to you, Dr. Prabani.
Thank you, Samira. Okay, so good morning, everyone. So today's topic is exploring pediatric oncology, insights through case scenarios. Because this is a subspecialty and no one is like a lot of people are not aware of the basics. I thought of starting with the basics. So my objectives would be, I will just talk about a slide on cancer basics. And then I will move on to types of pediatric cancers. Again, a very brief introduction. And then I will move on to the case scenarios, which will be more entertaining, I would say. So I will start with the cancer basics. Right. So cancer, in very simple, what is it? It's not one disease, but it's many, all sharing a profound dysregulation of growth. So, and there are so many lengthy descriptions as well. Now, we all know these hallmarks of cancer, which is given in Robin's pathology book. We all used it during our faculty period. And right. So, evading growth suppressors, enabling replicative immortality, tumor-promoting inflammation, activating invasion and metastasis, genome instability and mutation, inducing angiogenesis, resisting cell death, then dysregulating cellular energetics, sustaining proliferative signaling, and avoiding immune destruction. So all these cause the cancer and their progression and their metastasis. And then when it comes to cell of origin, we have different types of cancer. Carcinoma is originated by epithelial cells. Sarcoma, the cell of origin is connective tissue, bone and muscle. Leukemia, hematopoietic stem cells. Lymphoma, reticular endothelial system. Lymph nodes, melanoma, melanocytes, germ cell tumors from germ cell. And there are mixed types as well. So the main difference between carcinoma and sarcoma, carcinoma spread through lymph nodes. And that is why the TNM staging is very important. So the tumor they start spreading via the lymph nodes. Whereas sarcomas, they go through the bloodstream. So usually their metastatic sites are bone marrow, and lung. Right. So the treatment modalities. So this is again a way, extremely like a precise or very superficial overview, I would say. So there are three modalities, main modalities of treatment. So surgery, radiotherapy, and systemic therapy. Surgery and radiotherapy are local treatment modalities, and systemic therapy is our chemotherapy. So when it comes to surgery, so good old days, what we had was surgery. For instance, like a few decades ago, for Ewing sarcoma, what we had was surgery only. So the survival was around 30%. So it went up to 70% with the help of other modalities of treatment. So when it comes to surgery, these things are very important. So that is why whenever there's a oncological diagnosis is suspected, better to get it done by an oncological surgeon. So if it's a lipoma, we just need the surgical excision of the lipoma. Cut can be minimal and there's cosmetic issues as well. But in our cancers, there's this microscopic spread. So you see the visible tumor, and then you take an additional margin. So we always call it a wide local excision. And then we always try to take the tumor as an en bloc dissection. So we take the whole tumor bulk together without cutting into the tumors, which minimizes the tumor seeding and seedling. And with all these, components, we try to achieve an R node dissection. What do you mean by R node is? So it has to be macroscopically and microscopically negative for tumor. The margin should be negative. So in order to do that, you have to take a wide local excision and you have to take the whole tumor bulk out. So that is where you need a lot of planning, and in cancer, no point leaving at least a bit of a macroscopic tumor. So that surgery is similar to, most of the time, that is similar to a biopsy. Only thing, and there's a big disadvantage there, because the post-operative healing time is prolonged and it delays our chemotherapeutic, administration. And always, all these carcinomas, we need lymph node evaluation. So when there's a lump, we always image the adjacent lymph nodes, see whether they are involved or not. So oncological surgery planning is much more intensive and extensive than a normal surgical excision of a lipoma or a benign lump. So the other thing is radiotherapy. So we have teletherapy and brachytherapy. So teletherapy is like we are treating from far away. So where the surgeon cut opens and take the tumor out, we are trying to treat these with beams. So X-rays we still have bit of old cobalt machines. So that is a radionuclide. So we have an entry beam and exit beam. So it's like a bullet. So what happens there is you kill the tumor cells by these radioactive substances or like X-ray, therapeutic X-rays. So the only problem is when the beam goes through the body, it goes through the normal structures and it exits through the normal structures as well. Because of that, there are some side effects, and I'll come to that. And then brachytherapy. Brachy means close proximity. So cancers like cervical cancer, we can treat without an entry beam. So because we insert a radioactive probe to the tumor itself, and because of that, the adjacent normal tissue radiation is minimal. And then when it comes to systemic therapy, we have chemotherapy. So chemotherapy started during World War, where they used this mustard gas to kill the soldiers, but then they identified the tumor cells or the lymphomas have gone down. So they invented chemotherapy during that era. So chemotherapy kills all the rapidly proliferating cells. So that includes hair, skin, GI tract, and bone marrow. So because of that, the toxicities are common in those systems as well. And the new kid on the block is targeted therapy. So we have to remember all Ganon intracellular and extracellular pathways, MAP kinase, RAS, RAF, MAP kinase, MEK pathways. So they target the specific, targetable sites. So the important thing is side effects are less and if at all different. But only thing is this is not a kill per se most of the time. We switch off that, dysregulated path, but then we don't know what will happen when we chemotherapy. So we don't have decades worth data yet. So these are relatively new treatment modalities, but very effective. Right. A little bit of radiotherapy because we all are doctors. We have to know what's happening. So this radiotherapy planning is really cumbersome, takes time. So we do a CT simulation. That is where we plan the radiotherapy planning. So basically, in each and every cut, we have to draw the tumor. And then we make a 3D model. And then we add an additional margins for the possible microscopic spread and for movement errors. So we make 3D images of these, and in each and every cut, we have to draw the risk organs as well. like here in the spinal cord, we have drawn. So again, a 3D structure of that. So then with the help of physicists, we make a plan and we calculate the dose to the tumor and for all the risk organs separately. And the ideal plan would be to give a maximum dose to the tumor and minimum dose to the risk organs. And there are calculated tolerance doses. So we know what are the cutoffs and whether we can approve this plan or not. So that is a little bit of the cancer basics and treatment modalities. So moving on to the pediatric oncology. So the main types of cancers are hematological, solid, and brain. So hematological, we have leukemias and lymphomas. The commonest one is ALL, and out of that we have B and T ALL, and then AML, CML. That is ALL is acute lymphoblastic leukemia, AML is acute myeloid leukemia, CML is chronic myeloid leukemia. Lymphomas, Hodgkin lymphoma and non-Hodgkin lymphoma. And when it comes to solid tumors, so in adults, we see breast cancer, colon cancer, head and neck cancer, all these are carcinomas. In pediatrics, the common ones are sarcomas and blastomas. So in eye, we have retinoblastoma. In lung, we have pleuropulmonary blastoma. Liver, we have hepatoblastoma. Kidney, we have nephroblastoma. So all these are blastomas, and sarcomas, rhabdomyosarcoma, the soft tissue, the commonest one we have, and then Ewing sarcoma and osteosarcoma, the bone cancers. And apart from that, we have melanomas, germ cell tumors as well. Brain tumors, so we have glial tumors, cellular tumors, pineal gland tumors, meningiomas, and then embryonal tumors, medulloblastomas, and intracranial germ cell tumors. So earlier I discussed, when I discussed about the treatment modalities, I discussed the importance of taking the en bloc dissection or a wide local excision, which is not possible in brain tumors because we cannot cut into the normal brain tissue, and because that will leave a huge neurological deficit. So here the brain tumors, it's always a piecemeal surgery. So how do we know whether there's a postoperative residual volume? So it's a must to do a postoperative MRI scan within first 3 days of the surgery to reduce the artifacts. So ideal setting in the UK, what we do is immediately after the surgery, the same GA, we take the patient to the radiology department and we do a postoperative contrast enhanced MRI scan. Because CT is just to see the hemorrhage, but in order to see a postoperative volume, we have to do a MRI scan. So it's very important to do the proper imaging pre and post. So we'll move on to the case scenarios. So I will start with the first one. So case one is 8-year-old boy presenting with fever and cough for 6 days duration. So our kids are healthy. If you have transferred one of these kids, you know they are relatively well. They are not acutely ill. So this full blood count is 78,000 microliters, and hemoglobin 6 gram per deciliter, and platelets 60,000. So if you take two scenarios, one child with 20,000 count, relatively like really ill, and the second one with 20,000 WBC with relatively healthy running around. So the first one will be having severe sepsis with left shift of neutrophils, toxic changes. So that is why the neutrophils are high to fight the infection. Whereas these kids, they are relatively well, they have fever, but they are eating probably slightly less, but they are active. But then high counts, that is very suggestive of a malignant process. Saying that normal counts, perfectly normal counts, still have, like, they can be leukemias. In fact, if you take most of the leukemias, most of them are having normal counts. So this one is having a high WBC, low hemoglobin, and low platelets. So what are the initial steps of management? So we have to do an urgent blood picture. And definitely platelets has to be, so we have to think about platelet transfusion if there are bleeding. So what are the criteria? Less than 10, we have to transfuse. 20 and fever, we have to transfuse. And 50 and there's a bleeding tendency, we'll have to keep the platelets more than 50,000, right? And chest X-ray to see mediastinal lymphadenopathy or mediastinal mass. It's very important because sometimes if you are not looking into those, they can have sudden shortness of breath and there can be tracheal deviation and mediastinal shifts as well. And we have to send bloods for tumor lysis markers. So I'll come to this in detail in my second case. And we have to hyperhydrate these patients. So hydration is maintenance fluids. Hyperhydration is 125 ml per ml per meter square per hour. So we do a lot of calculations per meter square. That is, we calculate the body surface area. So there are calculations you can see online as well, and there are tables, but you can always contact us to get the hydration volume. So that is 125 ml per meter square per hour. So if we say the body surface area is 1, roughly in a 10-year-old, that would be the case. So they should get 125 ml per hour. So that's a larger volume compared to the maintenance fluid. So this is to, help to excrete all the cell metabolites. And allopurinol, again, I will come to this in my second case. So these are needed to prevent tumor lysis syndrome. And the bigger question, so like you have these patients in your peripheral hospital. So you you send all the bloods and you suspect leukemia, you contact us, you start hyperhydration. Allopurinol, if you have, otherwise still fine, hyperhydration is the key. Send the tumor lysis markers if you have. X-ray, if possible, please. And then do you going to blood transfuse as well? I would say no for a 6 because the problem is hyperviscosity. So when the counts are high, they tend to have hyperviscosity and ICH. So the red cell concentrates are having high viscosity. Platelets transfusions can be readily given if they fulfill criteria. That's okay, but not red cell transfusions. If the patients are asymptomatic and not in heart failure, check palo, not just the hemoglobin count. If you think patients are not symptomatic, so please delay the red cell transfusion. Transfer with 6 hemoglobin is perfectly fine, right? And oncology referral is promptly should be done. So this is again to show our bone marrow report. So you don't have to have a bone marrow report to transfer any of these patients, because always discuss these patients. We are happy to take over them with pending results, suspicious of leukemia. We are all happy to take over these ones, and we are happy to do the bone marrow studies. And if they don't have malignancy, we are happy to transfer them back as well. So because this sort of a comprehensive report can be given only at Maharagam and very few hospitals. So rather than doing do bone marrow studies back to back, we always encourage them to transfer with proper hydration. So you can see the full blood count reports, blood picture reports, and then aspiration reports, and then the stains, the PAS and Sudan blood, and then they give a morphological diagnosis, and we can run the the flow cytometry. So we have B markers, T markers, myeloid markers, and immature markers. So immature markers will be positive in leukemias, and those will be absent in lymphomas with bone marrow infiltration, which is slightly different. And B markers are positive in BLL, T markers are positive in TLL, and then myeloid markers are positive in AML. So then we do take blood for, so the same aspiration sample they can run the flow cytometry, and we take separate samples for genetics. Currently, we cannot do full panels at Maharagama, but then we will be starting this very soon. I think our hematologists are super enthusiastic in doing this in the government sector. And then we take a strepine sample as well, which we will get in a few days to weeks time, because that's a morphology analysis. And then when the counts are high, more than 50,000, we can check this morphology, flow cytometry, and even do the genetic studies by the peripheral blood. So we have a dedicated bone marrow theater running all the weekdays and even on Saturdays for the diagnostic purposes. So we have a separate anesthetic team. We give GSO. It's very easily done. Every day, I think we are doing 10 to 15 bone marrows. So it's not a big hazard. We can arrange it readily. But then with high counts, we don't even have to give GA, general anesthesia. We can do it peripherally with the peripheral blood sample. So the learning points here are we have to have these hematological malignancies in your DTs, differentials, and hyperhydration or at least IV hydration during transfer. So whenever I get a call from the peripheral hospital, what I say is, if the platelets are like, extremely low, transfuse, then start hyperhydration, put a cannula in or two in that matter. And then during transfer, if you are not sure a child is about to get overloaded, then at least, turn back to maintenance fluid and send us with a saline. Always send us with a saline. Because there was this transfer from a peripheral hospital. Child with 7 lakh or 9 lakh counts without a cannula, patient transferred. Patient was already confused. We cannot even put a cannula once the patient was here. Patient died in few hours time because patient was having hyperviscosity. Because if that sets in, the management options are extremely limited, like plasma exchange or something like that. But I think during at that point, we cannot do much. So always put a cannula the moment you see a full blood count of, high full blood count. They need a cannula invariably. And caution with blood transfusion, delay if possible, and urgent transit to a tertiary care center, which is uh, needed. And the second case, 10-year-old boy referred to an ENT surgeon for tonsillectomy. Tonsillitis is very common in children, isn't it? So presented with increased snoring, fatigue, sore throat, enlarged tonsils, and gradually increasing painless and non-tender cervical lymphadenopathy. Characteristic of tonsillitis, I would say. And 2 days before the scheduled procedure, his parents took him to a local emergency department after he had been unable to sleep because of congestion, sore throat, and difficulty in breathing. Again, seems like tonsillitis worsening. On examination, nasal congestion, enlarged tonsils that touched in midline, and significant anterior and posterior cervical latinopathy. So these patients present to the GP or local doctor. Now you have a date to do the surgery in 2 days' time. Why don't we do the surgery, isn't it? And manage with a bit of steroids, which is, I would say. So this article was taken, this is a case report written in another country. So this practice or malpractice is happening elsewhere as well. So always, without going into steroids and antihistamines and manage like this, do a full blood count. That is what is needed. So what happened in this case was the doctor has given steroids and loratadine and discharged. So in the following days, so the next 36 hours, patient's congestion and breathing improved. Obviously, steroids, do, marvelous jobs. So they improved to somewhat, but then patient developed vomiting repeatedly. So he turned to the emergency department where he appeared ill and was found to be moderately dehydrated. And now they have done the bloods. Full blood count, the WBC is sky high, 84,000. Potassium high, so bicarb low, so in acidosis. Phosphates high, calcium low, uric acid high, LDH high. Chest X-ray shows a small mediastinal mass as well. So this child is in tumor lysis syndrome. So pretty normal. Because of that, it's still biochemical tumor lysis. So patient is having most likely a hematological malignancy. So there are lymphoblasts. So basically it's leukemia. So the blood picture, level of the blood picture, they confirmed it's leukemia, and patient is in biochemical tumor lysis. So this patient would have given hyperhydration at least in the prior admission. So in that case, they would have had all these cell particles properly excreted via kidneys. So on top of that, patient was vomiting. So patient did not even get the maintenance fluids. Patient was vomiting, dehydrated, definitely make the situation extremely worse. So next day, the creatine has gone up. There's an acute rise, so acute kidney injury. Now the patient is in clinical tumor lysis syndrome. So these patients need dialysis readily, promptly. Delay in dialysis can be lethal. So the diagnosis has made as TLL with the help of flow cytometry. So little bit of tumor lysis. So we all learned this in our biochemistry in our first years of medical student period. So if you see this, so this is the xanthine oxidase pathway. Allopurinol stops uh, the xanthine oxidase and prevent forming uric acid. Uric acid is insoluble. So this allopurinol can only stop making uric acid, but then it cannot act on the uric acid already made. So that can be tackled by rasburicase, which is extremely expensive, which is not available in the government sector, which is not freely available in the private sector as well. So our job is to prevent forming uric acid. So hyperhydration is the key, I would say. If you think the patient is getting overloaded, give furosemide. I would even start on regular furosemide or even furosemide infusion if you cannot extract these readily, because otherwise patient will die of tumor lysis. Or else, if you cannot get rid of the fluids with Lasix, make sure you arrange early dialysis. So what is tumor lysis? It's life-threatening complication, arises when the rapid lysis of tumor cells leads to the release of excessive quantities of cellular components into the systemic circulation, resulting in a metabolic disturbance characterized by hyperkalemia, hyperphosphatemia, hyperuricemia, and hypocalcemia. So high potassium, high phosphate, high uric acid, and low calcium. So the phosphate is the first one to rise. So make sure you send the phosphate and make sure you get the result as well. Because usually we are prone to send electrolytes, which has calcium, which has potassium, but then we don't have the phosphate report. So make sure you send phosphate and make sure you get the report as well. Because sometimes some hospitals, they don't have the reagent. So even if the patient can afford, make sure you do that or transfer or at least hyperhydrate properly if you think patient is going to tumor lysis. So tumor lysis can trigger sometimes spontaneously when the tumor bulk is very high. So, and then a small dose of steroids. So the other thing is patients with lymphoma, so are waiting for imaging, past history of, bronchial asthma. So the without giving a proper history, say like, prepare these patients with steroids. And next day, these bulky lymph nodes can be disappeared. So you will never be able to make a proper diagnosis if you don't look into these problems very carefully. So make sure you discuss with the radiology team, make sure you are attending if there's a high risk of anaphylaxis, try to do the imaging um, uh, without steroids. And because it's very important to know the distribution of these lymph nodes and take a biopsy before giving steroids. And after the biopsy, if you have to give GA, then you can, give a dose of steroids. If you are sure that you have taken adequate, sample to analyze histologically. So what happens is this crystal induced tissue injury occurs when calcium phosphate, uric acid, and xanthine precipitate in renal tubules and cause inflammation and obstruction. So this metabolic derangement may lead to acute oliguric renal failure and cardiac arrhythmias. So the learning points here, do the blood investigations, though the patients are waiting for a surgery. And then tumor lysis markers. Hyperhydration is the key, and allopurinol if it is available at your hospital. And please and plan early dialysis if necessary. So we move to the case 3. 9-year-old girl diagnosed with BLL, admitted to the local hospital with fever following chemotherapy. So the people who are in Colombo hospitals may not come across this situation. But then if you are at a periphery, because all these patients time to time go home in between chemotherapy. So this is a common presentation to the peripheral hospitals. So what is the difference between a fever in a healthy child and a fever in a patient who received chemotherapy? So what would you do? So this is again, febrile neutropenia is an oncological emergency. So you cannot postpone seeing these patients. Yeah, so you have to go through the history and examination very quickly. So make sure these, just ask what sort of chemotherapy they have given. Probably are not aware of the details of the chemotherapy. At least ask when they have given, right? Because now antibiotics work within 24 to 48 hours. So that is why we change antibiotics on day 3 also. But these chemo work gradually. So the counts drop. So all the conventional chemotherapy, as I mentioned, most of the chemotherapy affect the bone marrow as well. So bone marrow, suppression or neutropenia causes on day 6, 7, 8. Sometimes the peak, the significant drop will be seen on day 10. So we call it nadir. So NADIR. So that happens on around day 8, day 10. So this patient received chemotherapy 8 days ago, 10 days ago. The patient is likely having now febrile neutropenia. So they are likely to have sepsis very rapidly. So, and certain cancers, so leukemias, we don't give colony stimulating factors, GCSF. So do not rush to give GCSF for all cancer patients. Just ask parents whether they are on GCSF or not. Sometimes the diagnosis card, they contain all these details, but if you're not looking into these, you may not know. And then recent history of infections, culture positivities, their sensitivity patterns. So this is our job to write these details when we are sending the patients to the peripheral hospital or when we are discharging, because you never know when they are going to admit to the peripheral hospital. If they are far away, if they are going home, it's our job to give a proper diagnosis card with their, sensitive patterns as well. And history of constipation, anal fissures, mucositis. I'll come to that why the bowel history is very important. Bowel habit history is very important. I'll come to that in my next slide. But then contact history of fever, current epidemics, recent surgery is very important, and presence of a central venous catheter. So those are ports or Hickman lines. Because those are not readily available in government sector, a lot of patients do not have these lines, but always inquire that whether they have a line or not, because then again, antibiotic policy and the risk of infection, the organisms also change. So urgent investigations, we have to send full blood count, CRP, lactate. So lactate is very important. In Sri Lanka, in the government sector, we cannot do serum lactate readily. It's not available. It's expensive. So when you suspect the patient is going into sepsis or patient is ill, make sure you do a blood gas. Venous blood gas is adequate to check the lactate level. Because sometimes the nursing chart, the blood pressure, because blood pressure is the last to go, blood pressure, heart rate, and respiratory rate. Sometimes you just, see the number, you don't see the trend. And especially when you don't examine, you don't check the cool line, you don't check the capillary refill, you don't check the pulse volume, which are more important in, which are more important early signs of sepsis. So always do examine these patients, sometimes have a monitoring chart. So I think the usual nursing monitoring chart is extremely inadequate. So make sure you incorporate, capillary refill or pulse, whole line, pulse volume, or these sort of things into your or map. Calculating map is very important. So these things into your monitoring chart, or you examine these patients, then and there without a delay. So liver, renal, electrolytes, blood urea, because these patients might be vomiting, these patients might be having diarrhea. So their electrolytes can be readily deranged as well. So a coagulation profile, urine analysis, especially when they are less than 5 years old, and chest x-ray, they often can get pneumonias. So these are the bedside blood investigations have to be sent readily, and blood culture. So when they have a central line, you have to take blood from peripheral and central both together, because we call it time to positivity. So if the peripheral blood becomes positive, that means the origin of the infection is not the central line. So in that case, you can, save the line, because these lines are expensive, and, we put a line to a patient because there's a need probably difficult IV access, or like, infusions and extravasation risk and all these. So taking this line out and putting a new central line which can delay the whole process of, chemotherapy administration. So we'll have to preserve the line when it is possible, and we'll have to take it out when it's necessary. So in order to make a sound decision, you have to have peripheral and central line blood cultures both together. But saying that, unless you know how to take blood cultures from a central line, you're not supposed to, access a line, because then you will have to heparinize in certain lines, and these strict aseptic measures to be adhered. So always contact us what to do with a central line if patient with a central line comes to your hospital. And second line investigation is going to be like HRCT, bronchoalveolar lavage. So a little bit about febrile neutropenia. What is the definition? So oral temperature 38.3 over 38 over 1 hour, and absolute neutrophil count less than 0.5, or absolute neutrophil count less than 1, and expected to fall, that is like, given myelotoxic chemotherapy in the next 48 hours. So what are the commonest uh, infections we do see in our setting? It's always viral infections. I mean, doesn't matter it's the oncology ward or the non-oncology pediatric ward, or in that matter in adult wards. It's always the viral infections we come across. But 1 in 1,000 or 1 in 100, we see these patients. So gram-negative sepsis, gram-negative infections, and gram-positive infections. So whenever there's an artificial line, like urinary catheter or central venous access line, both, they tend to, the gram-positive organisms such as Staph aureus make a biofilm. So because of that, they can have gram-positive infections. So whenever there's a patient with a port or a double, like a Hickman line, add teicoplanin or vancomycin to your antibiotic cocktail. So the way of identifying is if you're accessing the line, after accessing the line, if they have chills and rigor, so that is where they disseminate all this, toxin, the Staph aureus toxins to the bloodstream, they get chills and rigors. So make sure you get that history. And if that is the case, that means that line has to come out. It's most likely a Staph aureus producing toxins. So very difficult to salvage that sort of a line. Right. And the other thing, the common one in our setting, because we don't have much central lines, is gram-negative sepsis or gram-negative infection. So our chemotherapeutic agents cause constipation. Ondansetron and other, supportive care and morphine, other supportive care medications cause constipation. Then our children lose appetite and their oral intake is less. So if you don't hydrate properly during chemotherapy, they get constipation readily. So what happens is then their gut translocation of this gut bacteria translocate to the bloodstream. And when they reach nadir, or when they hit their lowest counts, they have gut translocation of bacteria to the bloodstream, and they will have this necrotizing enterocolitis or typhlitis, or the gram-negative sepsis, which is lethal. And this is the most ICU, this contribute to a lot of our ICU deaths. So make sure you look into the bowel habits, not just whether they have open bowel or not, their consistency, their frequency, whether they have straining, and there are a lot of ways of assessing bowel in detail. So there are questionnaires. So make sure you ask a detailed history with regard to the bowel movements. And you can see these X-rays, enlarged bowel loops, so with fluid levels. So whether that is obstruction or paralytic ileus. So what happens is this constipation leads to impacted stools. And then you cannot give any mass, or you cannot put a parectal dulcolax, because in neutropenic patients, because that can damage the anal mucosa. Because of that, you have to manage these patients very cautiously. And then when they have impacted stools, so they tend to have then gut translocation, and then they will have typhlitis, and uh, then like some rarely they can have bowel obstruction as well, which is almost lethal. So the learning points here: fever may not be even present. Sometimes they just have little bit ill, and if you examine, they have a very poor pulse volume. They might be having a poor line. Deterioration can be acute, may appear normal until they collapse till the last minute. And urgent antibiotics are needed, ideally within the first hour of admission. So admission to the antibiotic, the administration should be less than 1 hour. Look into the early signs of sepsis, importance of checking pulse volume, capillary fill, pulse pressure, map, degree of dehydration, urine color, and output. Always look for the infective focus. So our institutional guideline or the national guideline, in fact, the national guideline is the first line for all the febrile patients with neutropenia, both piperacillin and amikacin. So because of the resistant patterns, our microbiologists have written this guideline. It's available at Maharagama. So the first line is piperacillin and amikacin, and if they have a central line, we have to add teicoplanin. So basically, they need piperacillin has gram-positive and negative cover both, and amikacin and to the bacteriostatic activities. But if they have a line, we need an additional gram-positive cover tackled by teicoplanin. And always do a blood gas analysis, which saves lives. Move on to the fourth case. 11-year-old girl diagnosed with BALL on maintenance therapy, presented to the clinic. So this is again for all the doctors working at their peripheries, because this is the time they go to their homes and they come to us weekly or sometimes even 2 weekly or monthly basis. So they come with this sort of a book. So the WBC is 4,000. Then hemoglobin is okay, and platelets 90. So for a patient with leukemia, I mean, because they are having deranged blood counts throughout their life. So you might not see the difference. You might just continue the same drugs. So usually what happens is during this last, treatment phase, we give a plan and they go to their local hospitals, and then the MOs or the peripheral consultants follow these patients up. So, I mean, all this time their counts are be deranged. So you might not even, like if the child is well, you might not look into the count details. So that is why I'm highlighting this. So what are the DDs? So what is the problem? So WBC is slightly high actually. I'll come to that, and platelets are low. So this is the book we are giving. We call it this a Gedarapota. So Ammala, like parents definitely know this Gedarapota and Gedarabed. So how to read this? So this one cycle goes up to 3 months, precisely 12 weeks. So this is the first month. This is the second month, if you can follow my arrow. And this is the third month. So these 2 pages are dedicated to one cycle. And this left-hand corner, we write the chemotherapy and the prophylactic drugs. I know, this is very hard to read if you're not familiar. For us, it's very easy. VCR is vincristine, dexamethasone, MTX is methotrexate, and then this sometimes some people write Cotrim, sometimes write Bactrim. So that is the prophylaxis against PJP, pneumonia, and then they have written 6-MP, that's 6-mercaptopurine, that is again a chemotherapy. So basically patients are on IV chemotherapy, that is vincristine, monthly basis. They every first week of the month they receive a dose of vincristine. Because of that they have to come to us. So monthly basis they are anyway coming to us. And DEXA they are giving in the first week of treatment, first week of month. So all these 3 weeks they are getting dexamethasone pulse. So 5 days. And then methotrexate goes weekly. So every every Thursday they are getting methotrexate in each week. And then prophylaxis, this is we are giving 2 days a week. So probably we keep it a weekend, Saturdays and Sundays. Doesn't matter. We have to give it in 2 days BD per week. And then 6-MP goes daily. So this is the book. If you're not familiar, always contact us when they come to you all. So before going into the DDs, so what is the management? So leukemia is a lengthy treatment. So it has induction, consolidation, interim maintenance, delayed intensification, and maintenance. So we induce treatment, we make them, we take them to a remission. So ideally at the end of 5 weeks, their bone marrow should be clear. All this, 3 years worth treatment is to maintain that, remission, because leukemias are nasty. So this is for ALL, not for AML. AML has a very relatively shorter period of treatment. This is for BALL and TALL. So consultation, so we have re-stratified treatment. So there are 3 regimes. I'm giving the rough, timeline so that, you can have a rough, idea. Consolidation treatment, 3 to 9 weeks, interim maintenance around 8 weeks, delayed intensification again 7 to 8 weeks. In those first 4 phases, they are usually with us, unless they want to, they're adamant of going home, saying that they haven't gone home for ages, or there's something happening in the home. We try to discharge them for a very short period, but they are in and out with us. And the maintenance, so we calculate this 3 years and 2 years from interim maintenance. So that is from here. Because the reason why the boys get prolonged treatment is because one of the sanctuary sites are testes. So the sanctuary sites are CNS and testes. So that is why part of treatment we are giving intrathecal methotrexate. We do a lumbar puncture. So in the bone marrow theater, we have this facility as well. One of our doctors in a roster, they go daily. We do probably 10 to 20 lumbar punctures per day, and we give intrathecal treatment daily, all working 5 days. So maintenance, because the males have testes, it's one of the sanctuary sites, they have a prolonged treatment time. And the maintenance, these are the cutoffs. So WBC ideally should be 2,000 to 3,000. So this one is having a bit of a higher WBC count. Platelets 100,000. Absolute neutrophil count should be 1,000 to 1,500. So we usually titrate. So when the counts are high, please contact us. And if the patients are not willing to come to Maharagama, let us know. So we will over the phone manage these patients. We are more than happy to answer your calls. So we have to titrate this 6-MP and methotrexate, and relapses are not rare. So make sure that, you have that, in your mind, and we have to check the compliance as well. And some sort of chronic, infections like fungal and CME can alter the counts as well. So the differential. So we have to check the week, because first week, as I mentioned, they get steroids. So following steroids, they can have a bit of a high WBC count. They can have infections. Viral infections cause low ANCs. So which is again common. Compliance, need to check. Hypersplenism can cause low platelets. 6-MP can cause, again, low counts. And especially with the poor brands, poor quality brands. And then immune thrombocytopenia, which is not that rare, because all these most of them receive platelets in numerous transfusions throughout their life. By the time they reach their maintenance, some may develop immune thrombocytopenias. So you have to discuss with the transfusion team. And relapse, again, this is the typical picture. So you don't have to analyze all this, but make sure contact us. So be vigilant with the full blood count parameters and do not hesitate to contact us. I think that is the message. So I know that you're a bit fed up with all the cases. So I will run a few more cases in a very brief manner. Right. Case 5. 10-year-old boy on regular MOH clinic visits. Mother noticed a difference in the eyes. How do you approach? Now the child is already 10 months. So when mother sees this, so this is actually a bit of an advanced age. So the message, so this is a retinoblastoma, nothing else. Cannot be anything else. So the important message is this: if they are intraocular, the survival, the cure rate is more than 95%. If they go out of the orbit, and because of our ignorance, survival becomes less than 5%. So it's up to us doctors to see that. So the early phase of management just need local therapy, bit of chemo here. And here it needs a lot of treatment. Here the eye comes out, and here largely incurable. So the learning points, use the ophthalmoscope to in routine examination of a neonate. Please do that. Right. Case 6, 16-year-old boy with hip pain and 2 episodes of falls. If you listen to 100 cases of bone cancer, all have falls. So there's a history of trauma in all these. So it's either coincidence or either that is the first instance they have come into their notice, or else because of the underlying pathology, they had a fall. So always do not mislead by the trauma history. So always, objectively see these patients. So if you see this X-ray, I mean, not all are familiar with X-rays and not experts in um, analyzing X-rays. So if you're not sure, discuss with your radiological leads. I think that is the key point here. But if you see, there's a lytic lesion here. And these are real cases of patients. So if you see the CT scan, you can still see the lytic lesion. So this is a case of an osteosarcoma. So then, so little bit about osteosarcoma and Ewing sarcoma because they come hand in hand. So osteosarcoma is seen in bit more elderly, children, so adolescents. The site is the metaphysis, which is here in between diaphysis and epiphysis. So they don't have constitutional symptoms such as fever. They can have localized symptoms. So they know there's a progressively enlarging fusiform mass. So the thigh is getting larger or the limb is getting larger. They have a limb, they have pain, but that's it. Otherwise, they're eating, they're drinking, and they're active otherwise. So this is the case with an osteosarcoma. This is the normal pattern. Always there are deviations. You never say never in oncology. So metastasized to lung and bone. Management is surgery and chemotherapy. So these are radio resistant relatively. But new trials are coming up with high doses of radiotherapy. But as of now, with the guidelines, this is the standard. So we always have to give pre-operative chemotherapy unless they discuss, because otherwise if the post-operative healing takes a long time with a massive surgery, everything can be delayed and they can metastasize during their waiting time. So preoperative chemotherapy, surgery, and postoperative chemotherapy. So that's the plan. And in Ewing sarcoma, on the other hand, they can have in less than 10 years, saying that adolescents also have Ewing sarcomas. It can be, so this is bone sarcoma, I'll be talking about an extraosseous Ewing's as well. But when it comes to bone sarcoma, so again, the site is diaphysis and axial skeleton. So they do have these in long bones or else in the spine. So which is very difficult to address locally, with the local management. So they do have constitutional symptoms. They can be fever. Often they mislead with this presentation with the osteomyelitis, and there are so many delayed presentations for months and months, giving loads of antibiotics without a proper histological analysis. And they metastasize to lung, bone, and bone marrow, all these sites. And they need preoperative chemotherapy, surgery plus or minus radiotherapy, and postoperative chemotherapy. So if the lesion is in a distal limb and we chop it out, if we do an amputation, then there's no place to give radiotherapy. So you can be you can manage with surgery alone. But if you put a prosthesis inside, always it has to be coupled with radiotherapy. So the learning points here, again, have bone tumors in your DDs. In a child or an adolescent, enlarging bone, like only differential, I would say, is a osteomyelitis when the site is, confusing. But have these DDs in your, differentials. So, and if you're not sure of this, ask your radiologist. Do not postpone or do not say there's nothing, and don't say that, you cannot have cancer. So make sure you exclude all the possibilities before saying that. Case 7, 9-year-old girl present to the ETU with acute shortness of breath. And this is the X-ray. So looks like a huge pleural effusion. So the night MO, the on-call doctor, inserts an intercostal drainage tube, IC tube. And unfortunately, he has gone into the tumor. So the whole lung, the hemithorax was occupied a solid tumor. Now, obviously, the shortness of breath has not been addressed. On top of that, you have made an artificial seedling line. So the whole hemithorax is now contaminated because of the IC tube insertion. So this is tricky. Always get your senior help. Always get the other help of the other specialties, I would say. So this is a case of an extraosseous Ewing sarcoma. Again, they can present, the germ cell tumors present like this, and neuroblastomas can present like this, lymphomas can present like this. So there are a lot of uh, uh, thoracic tumors can present like this. So the take-home message is proper examination and discuss the X-ray with your radiological exam. I'm pretty sure a lot of, I mean, a lot of hospitals they have at least surgical radiology on call person, and you have your colleagues. So discuss that, and even in the absence of CT, you have ultrasound chest can be done readily even at a night. So if you're not sure, I mean, discuss with your ICU team. But rather than going for an ICU blindly, make sure that you have looked into all the other aspects as well. I mean, see the trachea is here, like massively deviated as well. Case number 8, 16-year-old boy with scrotal swelling present to the ETU. Very common. Common things are torsion, epidermolysis, but then do not stop at that point. Do not just stop at, prescribing antibiotics and relieving. So always do the ultrasound of the testes. So you can nicely see the solid tumor inside. Because if you rush thinking that it's a torsion and do a low inguinal or inguinal orchidectomy, the management will not be in our books. So it's a very artificial situation, completely mismanaged situation. So always get the help of your imaging and make a rational, like a comprehensive diagnosis. So always do the imaging. And the other case, 14-year-old girl, again presenting with an abdominal mass to the ETU. So it's a huge mass. So germ cell tumors are essentially midline tumors. This is a huge mass. Do not rush to do a surgery. Do tumor-lysis. Any midline mass, do tumor, not tumor-lysis markers, sorry, the tumor markers, that is alpha-fetoprotein, beta-HCG, and LDH. So if those are high, you don't need even a biopsy. You can straight away go ahead with chemotherapy. So what happens? These tumors are extremely aggressive. And if you do a surgery and while you are waiting for the post-op recovery, the mass regrows even to a larger volume. And I have seen patients die without being able to receive the first dose of chemotherapy. Because if you suspect peritoneal dissemination, there's no point doing a surgery upfront. Always refer to us for chemotherapy, and we will always refer back to you all once the neoadjuvant or the preoperative chemotherapy is done, because they all need local treatment. There's no doubt about it, because otherwise they become palliative. But then they need neoadjuvant or preoperative chemotherapy. So, word about, so this is an ovarian germ cell tumor. So, the seminoma, germinoma, dysgerminomas, these all, were used interchangeably. So like seminoma is for the testicular tumor. Germinoma, we use that word for intracranial tumors, dysgerminoma for ovarian tumors. Yolk sac tumors, embryonal tumors, cholangiocarcinoma, teratoma, mixed histology can also present. So these are all germ cell tumors. Management is more or less the same as long as they have immature component or high tumor markers are there. So yolk sac tumors usually secrete alpha-fetoprotein, choriocarcinomas, beta-HCG, embryonal tumors secrete both, and mature teratomas, they don't secrete anything. But then immature components are there. Still, they can be having normal tumor markers, but then histology is important when the tumor markers are normal to evaluate the immature parts. or whether still there are active tumor component is there. And so these are essentially midline tumors. It can be intracranial or extracranial. Extracranial ones can be gonadal or extragonadal. So extragonadal ones are mediastinum, retroperitoneum, and sectococcygeal. And there's a bimodal age distribution even among pediatric and adolescent population. So if you see this graph, so the green one, that is sectococcygeal. So they essentially present in infants and like very young children. So that goes down with age, but the other ones go up. And then again, so you can see yolk sac tumors are, so very aggressive tumors are commoner in, again, young children. And again, so the teratomas are again common here. And the other tumors, again, they have a similar distribution with becoming old. So the learning points, these are, so the aggressive germ cell tumor. So it's a huge, it's a vast spectrum. Certain germ cell tumors just carry mature components only, whereas the other end can die within a day or two because of the aggressive nature. So aggressive germ cell tumors are rapidly progressive. Always do tumor markers in midline tumors before surgery. Any surgical intervention, before any surgical intervention, please do the tumor markers. In testicular germ cell tumors, always need high inguinal orchidectomy and not inguinal orchidectomy. And in ovarian germ cell tumors, need preoperative chemotherapy if complete excision is not possible. Right, case number 6. So you see a lytic lesion in this 5-year-old boy in L1 vertebra. What would you do? So just to, remember that, these differentials. So leukemia can have lytic lesions. So make sure that you do a full blood count and a blood picture, first of all. Ewing sarcoma can present in spine, which is a common site. Neuroblastoma deposits, usually in young children. 5 years is, the margin. And LCH, Langerhans cell histiocytosis, I'll come to that. And exclude TB, which is very important because it is commoner in our setting. Right. So Langerhans cell histiocytosis, is this a malignancy? Not really. So it's an abnormal proliferation of histiocytes, not a true malignant condition. So it involves basically almost all organs, like, many organs. Bone, skin, liver, spleen, lung, bone marrow, CNS. It can involve all this. It can involve few. So treatment involves chemotherapy because of that, they always discuss with us. So certain ones, just the surgical intervention is adequate. Certain ones need chemotherapy, and certain ones are having a very high mortality rate. Certain ones don't. So why is that? It's a huge spectrum again. So the lytic lesions in the skulls, characteristic. Skin lesions can be like, can look, different patterns as well. So this is again, so all these hallmarks, we developed when we did not know the molecular pathways in detail. Now we know those. So these are intracellular pathways, RAS, RAF, MEK kinase, MEK pathways. So this is again our Ganon. I'm speaking. So now this target the hematopoietic cell. So the arrest, if the maturation arrest is early, they can have high risk multi-system involved LCH, where they carry a high mortality. These are usually infants. They have hepatosplenomegaly, pancytopenias, nothing is being corrected, massive livers. They are ill, they can have skin rash, nappy rash. Sometimes, these patients go to the GP with a nappy rash for a long time. They just prescribe something for the nappy rash, they don't examine the liver, spleen, they don't do the counts, they don't see. So, these cases are from, the UK actually, like, still they can have a delayed presentation because we are unaware of what we have to look into. So when the arrest is later at the tissue level, tissue dendritic cell level, it can be just local, one system, one side, like just the, one lytic lesion in the skull. you just scoop it up. You don't need a, en bloc dissection or a wide local excision here, because it's a part of, you're inducing inflammation, and that is enough to, heal it. You just have to follow them up. So it's a huge spectrum. So this entity, they hardly die because of the disease, almost none. Here, majority can die if you don't, treat them properly. So the learning points, again, remember these differentials, do urgent full blood count and blood picture to exclude leukemia, and do basic investigations, including ESR, because ESR is a very crude marker, but which is very helpful to uh, know a chronic process of inflammation. And then prompt evaluation of the spinal cord involvement. Make sure you examine the reflexes. Make sure you do a proper neurology, because if spinal cord is involved, not just the bone, it's a neurological emergency. As well as, like, if we say it's a Ewing sarcoma, it's an radio oncological emergency as well. Right. In the last case, comment on. So this is a 3-year-old girl coming with fever. So comment on this fever chart. So fever chart is very important. The importance of chart, you see the pattern. Even a full blood, even a blood pressure or like respiratory rate and heart rate chart. So chart, shows you the pattern. So here, patient starts with high fever, and then it responded to probably antibiotics. Probably this one is having, sepsis, and then responded, and again the fevers are coming back. Now you're a bit confused as what is happening. So it's important to know all the differentials so that you can look into this. So it can be just secondary infection, viral infection and going into secondary infection, abscess formation, hospital acquired infection, partially treated infections, and develop resistance to a treatment. And last two are very important. Rule out malignancy, because the underlying immunosuppression, or like, in immunodeficiency situations as well, they, show some response, but then they will quickly have because of the underlying problem, they will have infections and even some malignancies, like, leukemias. The presenting um, uh, symptom can be fever, not just leukemia, lymphoma, and even the ones I discussed, like Ewing sarcoma, Mills tumor, they can, the presenting symptom is a part of the cancer itself. And the other important thing is HLH, hemophagocytic lymphohistiocytosis, which is very important. No, you won't see them very often. I think partly that is because underdiagnosed, because we are not looking into that. So what is hemophagocytic lymphohistiocytosis? So this is a severe systemic inflammatory syndrome. So this is HLH, and like different specialties call different names. Macrophage activating syndrome, HLH, and so many other names. Because whatever it is, I think rather than giving it a name, we have to underline the process. So this is immunological process happening. So this is a cytokine release, cytokine storm. So we understood this bit more during the COVID period. So that is why. So now there are a lot of immunological basis is being really revealed. So this is persistent activation of cytotoxic T, NK, and macrophages. So there are mortalities even more than a leukemia, if you see. So in the developed country, the leukemia survival is more than 90%, ALL survival. So here the death rate is 30% or more. So we have to, aggressively treat them, promptly treat them. Otherwise, we will not be able to save them. So it can be primary, which is going to be very unfortunate, who need transplant. Otherwise, they're going to be lethal. Like, so we have to have genetic studies. They present in early childhood, like during infancy. So their mortality is high without and from transplant. So perforin deficiency, immune dysregulations, and secondary causes with, severe sepsis, even dengue hemorrhagic fever, or cancer, or any other inflammatory process. So basically, this is your body's response, which is being dysregulated. Now, because of that dysregulation, now on the body organs are being attacked. So, so we see the milder versions in dengue hemorrhagic fever. So again, clinical features, high and unremitting fevers, rash, hepatitis, jaundice, enlarged liver, spleen, pancytopenia, lymphadenopathy. They can have neurology and confusion, seizures, even coma. So basically, it affects a lot of organs. And this differential, so it's very tricky. Like, whether this is the underlying process or whether it's the HLH on top of that. Because the problem is, it's a criteria. Like, you cannot just pinpoint and say, now, leukemia is pretty easy. You see blast, it's leukemia. But here it's a, like 5 out of 8 criteria. And most of these, crude criteria can present with other problems as well. Therefore, it's your expertise to know whether this is going towards HLH, which needs urgent, chemotherapy. So always these patients are being discussed with us and they are managed at Maharagama because etoposide, one of the key chemotherapeutic agents, is the backbone of treatment. Unless it's a post-infective, like, dengue, post-dengue, HLH, then it can be just managed with steroids, but delay in chemotherapeutic agents can be deadly. So if you go through the criteria, fever, splenomegaly, cytopenias, hypertriglyceridemia, hypofibrinogenemia. So all these are like, features of inflammation. And then we don't have the facility to do the NK cell activity. We don't have the facility to do the CD25. So it's always a clinical diagnosis. And ferritin can be, so more than 500 ferritin, more can be like significant, but then again, it's up to us to interpret which is going which way. And then if you think there's underlying cytokine storm is there, the treatment is immunosuppressants. So steroids are crude way of doing that. Sometimes in this case, most of the time, which is not that effective in along with the other drugs, it has a very good response, but with steroids alone may not be helpful. So key message here is make sure the DDs are in your mind, and urgent ferritin, and do the transfer so that, we can get on with the treatment. Right. Thank you.
So if you have any specific questions, you can contact Dr. Prabani, or you can email us on office313@gmail.com, and you can communicate regarding your specific questions. And given the time constraints, I think we have to conclude the session. Thank you very much, Dr. Prabani Maddumarachchi.
Yeah, I will just give one answer because I think there's one important question at the end. I think others are also. But then vaccination. Yeah, vaccination. Yeah, good question again. So vaccination, we would start after 6 months. And in leukemia, probably 6 to 9 months, or 6 to 1 year. So we do not give any vaccination during active chemotherapy. So that is because live attenuated vaccines we are not giving, because that can trigger the active infection. We don't give inactivated vaccines because the immunological response will be poor, because our chemotherapy causes immune suppression. So again, you will have to understand this is myelosuppression, that is neutrophils, and lymphopenia, or the immune suppression, which we don't check regularly. So because of that, I mean, if you check immunoglobulin levels, if you check T cells functions, those will be low. So we let them to grow their own T cells. We give them 6 months to 1 year. Solid tumors, practically 6 months. So whatever the guideline, at least we'll have to wait for 6 months. Right. Thank you. And I'm more than happy to answer all your questions. Either you can email me or text me. And I can write to Shri directly, or you all separately. Doesn't matter, but I might need some time because of my schedule. But I'm definitely going to answer all your questions. Thank you.
So thank you, Dr. Prabani, for the excellent lecture. So our sincere thanks again to Dr. Prabani Maddumarachchi, consultant in Paediatric Oncology and special interest in stem cell transplant, National Cancer Institute, Sri Lanka. And yes, again, if you have specific questions, you can email Sri on office313@gmail.com, and We'll get back to Dr. Prabani and then we'll get back to you. Or maybe if Dr. Prabani can share the email on the chat, they will be able to directly reach you. And the
Yeah.
participants, please find the link in the chat box and kindly give your feedback and answer the post-assessment questions. Then you can receive your e-certificate for participation.
Yeah.
So let's wind up the session for today. Thank you, everyone.
Thank you. Thanks a lot.